I work for the Italian National Transplant Centre, where I'm an inspector of tissue centres, and where I'm technically coordinating a number of European Union funded projects on safety and quality in tissues and cells. Thank you.
I'm Michael Strong, and I'm retired, but Dr. Luc Noel has brought me out of retirement and put me to work because I do have some experience in all the fields of transplantation, as well as blood transfusion and hemovigilance and biovigilance. So somehow my retirement's not going that well.
Luc Noel. Good morning to all. I work for the World Health Organization in a new department, Service Delivery and Safety. And I have been asked to take on the task of an organization-wide initiative on medical products of human origin.
Bom dia a todos. Eu sou Geni Neumann, trabalho na Unidade de Biovigilância e Hemovigilância do núcleo que coordena o sistema de gestão de notificação, investigação e vigilância sanitária da Agência Nacional de Vigilância Sanitária do Brasil.
Thank you very much. So, my task here is try to get in some discussion about the conclusions of this forum. So I will ask Deidre. Oh, Luc first? Yeah. Well, okay. Luc will open this, how can I say in English? I know. I don't know, but we will begin. Okay, Luc, thanks.
The question is, the strategies and challenges to consolidate the vigilance and surveillance of products of human origin. From a World Health Organization standpoint, it sounds very interesting. Cell, tissue, organs are very different, yet they were brought together in the guiding principles of the World Health Organization. They were brought together under guiding principle 10, which calls on surveillance, vigilance, to maximize the quality, the safety, and the ethics of both procedures and products. And this is picked up by the resolution of the 63rd World Health Assembly, 63.22, that insists that member states should equip themselves with vigilance and surveillance, and the Secretariat, WHO, should make sure information resulting from vigilance and surveillance is available to all. What we have been seeing in the last years, what the Assembly translated in the resolution, is the growing realization that to be truthful to the donors who've shared the body, we have to share the information we have with the community to maximize, to optimize the quality of the use of those gifts of the human body. Consolidate and vigilance. Vigilance and surveillance, and I like always to put both terms, starts with the patient or the living donor, and therefore the clinician, and ends in the hands of those able to make decisions, those able to react in a timely manner, those able to protect not only the living donor and the recipient, but also the clinicians, the authority, the health authorities. And therefore, when it comes to consolidate, there are to bring together cell, tissue, organs. There is the challenge of being competent. On the one hand, the clinician is a specialist, an orthopedic surgeon, is an organ transplant surgeon. He is a hematologist, and they belong to a different world. We need to have competence in identifying, and there is no vigilance without the care of the clinician to identify, to perceive something that is not an untoward effect, or to identify something that went wrong in the process, that is stopped in time, but that is worth being communicated to others because it's a lesson for the community. No one can replace the clinicians, and the clinicians should know that this is their best protection. Expertise, and they have to discuss, to report to competent individuals. Yet there is a need for consolidation, and consolidation beyond cell tissue and organ, consolidation to all medical products of human origin, and that's the sense of the initiative I have been charged with. The human body, the use of components of the human body for therapeutic purpose reflect a conception of humanity, shares risk, transmissible diseases, just to mention these, and in particular in the infectious risk. And the consolidation helps to anticipate. We all know that there has been infectious threats identified through organ transplantation that were subsequently observed at large scale in blood transfusion, for example, and reciprocally. Is that consolidation only across medical products of human origin? No, it's also across the various vigilance. And at the authority level, there has to be the link to associate problems with a preservation solution, with a blood bag, or with a device that is the responsible of a problem with the patient. Once again, the clinician. So it has to be built with stages, and it has to be built with respect for the clinical world and the expertise, respect for the authorities and their capacity to react, ensure the good progression of the health system and the benefit for the patient and the living donor. There are challenges to this. And the challenge is simply from a global standpoint, the diversity of countries. And that is why, from the WHO standpoint, tools that would facilitate the circulation of information from countries that have made the right choice, that have and have the possibility to do so, that are able to have an agency like ANVISA, where that integration exists, that have the possibility to have at clinical level focal points that to transfer the information. That information should be available to the global community. That's what we're trying to do within the Notify project. But I think I should stop. I probably exhausted my 10 minutes. Still 5 minutes? Good. Let's continue. So what are we doing? What would be the conception of a vigilance and surveillance system at country level? I spoke about the diversity. We know, for example, that 50% of sub-Saharan African countries do not even have a legislation for blood transfusion. 90% of them do not have a legislation for transplantation. And that starts with establishing responsibility. And vigilance and surveillance is a tool for the authorities, and a tool that bring together the operators, the producers, the clinicians, and the oversight this has to be described in the legislation. And there are several ways to achieve this. There may be, we all know examples of countries with different agencies overseeing blood transfusion, transplantation, even tissues differentiated from organs, and there is a tendency to create silos. And we're having to discuss challenges. Silos is probably the greater risk, because we are much better working together, because we can go further pushing the cart in the same direction, because an information that would be coming from the organs, and I heard here examples, and some of them are famous, or an observation with organs will allow to stop in a timely manner, or perhaps to observe that those silos have not made possible to react in a timely manner, to recall or avoid the use of a contaminated tissue product. There is value in reacting in a timely manner and reacting for good reason. The integration that this country has achieved by building up a system in a synthetic, analytic, conceptual manner is an ideal that, for example, European countries, and Deidre will discuss probably more of this, are on their way of achieving the organization of the oversights of medical products of human origin is evolving in these countries. From the WHO standpoint, it is essential, and perhaps I will now finish on this, to stress that there is no efficient vigilance without the close collaboration, each in their role, but communicating, interacting. The operators, the clinical team, the OPO, the producers, and the health authorities, the regulators, the epidemiologists, and the policymakers, because ultimately they are the one responsible, and they are the one protecting the clinicians. Thank you.
Thank you. Thank you very much, Luc. Well, Deidre, Deidre, we will hear your considerations. So please, just get some light to us.
Thank you very much, Oscar. Indeed, I'd like to tell you a little bit about some of the work we've been doing at a European level in trying to establish common approaches to vigilance and surveillance across the scope of tissues and cells. The projects that I've been working on have mainly covered hematopoietic stem cells together with all types of tissue, but also gametes and embryos, quite a different type of human substance that's used in clinical application. It's interesting when we look back at the work that we've done over the past 9 years since common legislation was put in place in the EU, to see what some of the general principles are that have come from working on vigilance in tissues and cells. One of the things that's come quite clearly through these years is that while we're learning lessons about vigilance, we're increasingly turning to other fields of vigilance, particularly hemovigilance and organ vigilance, to look at their experience. And we find enormous commonalities, general principles that apply across the board. The two main purposes of vigilance and surveillance systems would seem to be, firstly, rapid action. When something has gone wrong, to limit damage. So if one recipient has been infected by a human product, action has to be taken quickly to prevent others being harmed by products from that same donor, or perhaps that were processed in the same laboratory. So rapid action to prevent harm to others is the first purpose. The second is the learning. It's the didactic value of looking at what has caused something to go wrong, and how can that information be used to make the process safer in the future for future patients. When we look at the learning side, the didactic value of vigilance, it's actually quite difficult to find cases in any field across the medical products of human origin that are not of didactic value for every sector. Take, for example, a case of HIV transmission by organ transplantation, such as we had in Italy, and Taiwan also had, one due to a transcription error, the other due to a miscommunication error by fax of a test result. The lessons to be learned from situations like these are not just of relevance to organ transplantation, they're of relevance to any program that must test donors. So equally relevant to even in blood transfusion, but certainly in tissue transplantation and cell transplantation. Even when you think of incidents in a field that might seem strange to us, very different to us, the field of assisted reproduction. We had a loss last year in Italy of 94 embryos because of a failure of maintaining the liquid nitrogen level in the cryopreservation tank. The analysis of a case like that, the lessons that come out, in this case particularly about the contractual, the arrangement of contracts with service providers in the area of liquid nitrogen, are of extreme value, didactic value for any service that cryopreserves human substances that equally, of course, can be bone marrow, peripheral blood stem cells, heart valves, or skin. So the idea of keeping that valuable didactic information to one field and not sharing it widely across the spectrum would seem to be a real lost opportunity. And this is one of the messages that's come, I think, very clearly through the Notify project, where we are really trying for the first time to look at vigilance across the scope of these substances and to make sure that we can all learn from incidents that happen in other fields. Through the work in the projects in Europe, we've developed guidance for various fields. We've focused a lot of efforts on the topic that Luc Noel just mentioned, trying to raise the profile of vigilance among clinical users, providing guidance to them on their responsibilities to report, to detect and to report. We've looked at investigation, and the principles of carrying out a good investigation following an adverse incident are the same. It doesn't matter if it was a transmission of an infection by a blood product or a mix-up in the organ that was transplanted in a recipient. The lessons are common, and we're trying to make sure that we get that value of this learning across the board. We came out at the end of SOHO VNS, the most recent project, the title of which was Vigilance and Surveillance of Substances of Human Origin, with some general areas, principles of vigilance and areas that need to be addressed going forward. And I think when I list these for you, you will agree that they're common for vigilance across all substances of human origin. They're about the need for effective detection. We need the clinical users to not just see the problem in their recipient, but to associate it with potentially being linked to the substance that they transplanted. We've had a case of transmission in Europe of acanthamoeba by a very nasty infection by a cornea transplant. The recipient was clearly infected. The bank that had provided the cornea was following up with an investigation. Most people considered it was probably caused in the hospital where the transplant happened. But when the bank went to the hospital that had received the second cornea from the same donor and asked how their recipient was doing, they were told really terribly our patient has a very nasty acanthamoeba infection. That hospital had not even considered contacting the cornea bank to say, we have a problem with our recipient, we think maybe it came from the cornea. They didn't consider the possibility, and of course it had come from the donor in this case. So detection is critical, and this is critical across the board, whatever type of human product we're talking about. Reporting is essential, and we won't get reporting without having a no-blame culture. We can't punish people for reporting things that have gone wrong. If anything, as regulators, I think Jenny would agree, we should consider perhaps focusing our inspections on centres that do not report adverse outcomes, because everybody has mistakes, so it's important to encourage reporting. There need to be good systems in place for quarantining and recall where that's possible. Every centre thinks it will never happen to us, and they don't consider the importance of putting these systems in place, but this is critical. There needs to be very good investigations. If we don't do good investigations following adverse outcomes, we don't get the learning opportunity. We can't blame human error for everything. Human error is almost always a symptom of a systematic problem, a lack of training, a lack of staff, procedures that are not well enough identified. So we need good investigations. And most of all, we need communication, sharing the information learned. And this is where the Notify project has, I think, is really playing and will continue to play a very important role. And I think I will leave it there. Okay, for now. Thank you. Thank you. Thank you very much.
Thank you very much. Well, Mike, next we will hear some reflections about this.
Well, it's been very interesting for me to be engaged in this, the Notified Library project, which hopefully most people here have now heard about. But one of the interesting aspects is bringing together all of the different specialists into one room to discuss their particular issues, because it doesn't happen very often that organ transplanters, eye bankers, tissue bankers, blood bankers, regulators have an opportunity to exchange information with one another. Now, what are the challenges of biovigilance? So a little bit of history, I think, is in order here. Each of these specialists that we've mentioned have come along this pathway at different times and on different courses. And the blood bank programs, of course, had to deal with the issue of HIV transmission very early in the establishment of HIV as a new and emerging infection. So back in the early 80s, this became, of course, a significant problem across the world, but certainly in the United States, there were close to 10,000 infections resulting from a blood transfusion and or tissue or organ transplantation. So something obviously had to be done. As a result of that, hemovigilance systems began to be established in the early 90s, first in Japan and then in France, and the UK, and then throughout Europe. And as a result of that, the need to begin to communicate with one another was established, and the European hemovigilance system was put in place in order to meet and discuss common issues. I was very much in favor of the slide that was shown in this previous session, which is to say that if you can't measure it, you can't improve it. And I believe in the blood systems, at least, hemovigilance has become a important component of quality management, and I think we need to look at it in that respect. Now, Deidre has already mentioned that the issue of not having punitive measures applied to those who have these difficulties, and that's a critical importance, because almost all of these specialties don't necessarily want to tell everyone about the problems that they have or the errors that they've made. And this is a common component in all of the different specialties who deal with vigilance and surveillance. From hemovigilance, Obviously, we've moved on now to biovigilance to include all of the other products, medical products of human origin. And this is where the challenges begin to be met, because each is in a very different area, very different pathway in establishing vigilance programs. Most of these are done through data management for particular specialists. You heard in the previous session, for example, for the stem cell products, that because these cross national boundaries to a large extent, in fact now I believe over 50% of the transplants in the stem cell field are done through, in unrelated transplants, are done across national boundaries. So there's definitely a need for communication and establishment of systems to identify where errors and accidents have occurred. So the World Marrow Association, for example, has a reporting system that captures these events, and they are shared with the members across the international spectrum. The iBanking community has its own reporting system, particularly in the United States. The iBanking Association of America has a reporting system only for serious accidents that occur, not the events where there might have been a problem for a patient, but these would be only patient adverse reactions. So there is a lot of layering that goes on with reporting systems, and consolidating these is going to be quite a challenge. As it's already been mentioned, communication between specialists is a challenge, and we are at different levels of acceptability that reporting is okay. I know in the United States, the organ transplant community is very concerned that the regulators may be involved, and that somehow that's going to impact donation rates. In the blood banking world, we faced that back in the early 90s, and the same fear was present then. But what we discover is actually there is a partnership that can be gained with tremendous improvements in quality. Record keeping and quality management systems were not prevalent back in the 80s and 90s in blood banks, but now they are as a result of having regulators involved in understanding how to establish standard operating procedures, following good manufacturing practices. These are not necessarily onerous processes. These are processes that actually improve quality. We know, for example, in the United States that there are a very large number of organs that are lost that are transplantable because of errors that occur. They can occur at various levels. Cold ischemia time, warm ischemia time, transportation where the organ is lost and goes to the wrong airport or sits on a loading dock somewhere. If we can't capture those events, we can't really figure out how to correct them. So vigilance and surveillance brings that opportunity. We can capture these events, we can understand which ones are most frequent, and we can apply corrective actions and then measure whether or not those corrective actions will actually worked. In the blood transfusion world, for example, we've had a lot of focus on infectious disease because, of course, that's very prominent. The media like to play that up, and you sometimes get lots of publication about particular events that occur relative to infectious disease. But in fact, as we've captured the data on adverse reaction events, infectious disease is probably one of the lowest risks of blood transfusion. In fact, it's clerical errors, mismanagement of labeling and traceability that are the major problems. So this brings me to traceability, because that is an area that we really haven't solved. It's a huge gap. And when we have donation of organs and tissues, the communication gap there is quite dramatic. So if we are sharing a donor that provides not only organs, but corneas and tissues and perhaps heart valves that go to different places, and we have multiple processing centers involved, of course the organ recipient is generally the first one to be identified to have a problem, particularly if it's an infectious disease. And if they don't share this common donor identification, the communication between the entities getting materials from that donor can be lost. And we have multiple examples of that, particularly in the United States. where a organ recipient has been infected with HCV or HIV, but the tissue banks were not told that this was happened, and then tissue from that same donor is distributed and infection occurs again. So traceability becomes an important component of vigilance and surveillance, and thus the effort to try to establish standards of nomenclature, which of course is a significant challenge when you're dealing with different languages, but commonality of nomenclature. Actually, what do you call a femur or a portion of a femur? It's amazing how difficult that can be. In order to have a standardized labeling system which will assure traceability, those have to be established early on. And again, we are at different different pathways in getting to that point. The blood establishments now have accepted ISBT 128 as a labeling standard, and there's management systems in place for that. The iBank community is now in the process of developing nomenclature, and they've accepted ISBT. The stem cell, hematopoietic stem cell programs also have accepted ISBT as a standard because, again, crossing national boundaries and being able to trace problems that occur are very important. Organs are still early in the process, but that is very necessary. So there are many aspects of vigilance and surveillance that need to be addressed. It's very complex. We have different communities. We talk different languages. And to overcome those is a challenge, but it's certainly achievable if we can all agree to work together.
Thank you very much. Well, we will have 5 or 10 minutes for questions or suggestions or thinking, whatever. I want all the audience to share their opinion, and here you have the most important people in the field. So I think you have to take in account this and get the opportunity. Indeed, I know you very much, so don't make me just do you speak.
Good morning. In fact, my question, I think it's more about the Brazilian situation. It was very interesting to hear the comments about the European situation especially, but what about which kind of advances do you have today for Brazil in terms of this kind of vigilance and surveillance? For Dr. Geni.
Na verdade, a programação não previa que se falasse sobre a situação do Brasil, até porque nós tivemos um fórum durante o Congresso, que está encerrando agora. A ideia é trazer exatamente essa programação e ouvir os desafios para se consolidar. E a ideia não é falar sobre o nosso ponto de vista, mas essa programação que nós tivemos nesses 2 dias mostrou, né, do Fórum Nacional de Biovigilância, que nós temos muitos desafios, mas que o Brasil tem toda a estrutura, arcabouço legal, arcabouço de autoridade competente, integração entre os diferentes atores, no sentido que tem uma coordenação do Sistema Nacional de Transplantes que vislumbra as políticas para se fazer biovigilância no Brasil. Então, o nosso entendimento é que o Brasil está se encaminhando para, em pouco tempo, ter consolidado um sistema de biovigilância, como nós fizemos para a hemovigilância e levamos mais de 10 anos. E agora nós já podemos utilizar essa nossa experiência, a estrutura que nós construímos de vigilância no país, e nós acreditamos que em pouco tempo nós teremos consolidado a vigilância e controle e monitoramento de produtos terapêuticos de origem humana. Não fosse assim, né, nós não teríamos o apoio apoio que nós temos, né, dos organismos internacionais que respeitam e têm manifestado respeito pelo trabalho que o Brasil vem desenvolvendo nessa área.
Bom dia. Tá ligado? Bom dia, meu nome é Maria Eugênia, eu sou da ANVISA e primeiramente eu gostaria de parabenizar as intervenções da mesa, que foram excelentes e bastante acalentadoras para nós que estamos aqui no Brasil formatando o nosso Sistema Nacional de Biovigilância. Eu gostaria de fazer um comentário e talvez se vocês da mesa pudessem fazer um comentário em cima disso. Este ano no Brasil, nós lançamos, o Ministério da Saúde lançou o Programa Nacional de Segurança do Paciente. Pela primeira vez, a gente passou a ter na agenda do Sistema Único de Saúde no Brasil, do nosso sistema de saúde, esse tema como estratégico, o Programa Nacional de Segurança do Paciente. E tem sido um grande desafio para nós, na ANVISA, que trabalhamos com monitoramento, fazer todo o processo de integração entre o monitoramento das várias tecnologias usadas em saúde. Não só nós temos já tratado a hemovigilância, a farmacovigilância, a vigilância de produtos para a saúde, mas como é que o nosso grande desafio, como é que a gente integra todos esses processos de vigilância, porque o evento adverso, quando acontece num paciente, ele acontece numa única pessoa, né? Ele acontece num determinado paciente que sofre um dano. E muitas vezes, se a gente fragmenta as diversas vigilâncias e não dá conta de fazer um processo integrativo, nós nunca vamos chegar a aprender com os nossos erros e problemas, porque temos dificuldade de fazer um processo investigativo integrado. Então, gostaria um pouco de ouvir, pela experiência que vocês têm tido, sobre essa questão. Muito obrigada.
Well, the question was about the integration of the variety of vigilance and the challenge in itself. One has to start, and I would insist that there has been pharmacovigilance for years, and it's probably gaining momentum after having been half asleep, as it has in many countries. The driving force for vigilance has been in many countries medical products of human origin, and as was stressed by Dr. Strong, blood and hemovigilance. And for the reason we touch, that is, the product comes from the community. We owe the community to make the best of that product, products of human origin. One should see medical products of human origin as spearheading patient safety for product safety, because the recipes are well known, because the risks are higher than other products, because there is in every hospital with some activity, a blood bank, an entry point for medical products of human origin. In a large hospital where there are organ transplantation in routine, tissue transplantation in routine, you may have other organizations, but the step in tracking, and I know this country is using ISBT 128 in blood transfusion, and ISBT 128 is the information standard for blood and transplants that in the medical products of human origin initiative of WHO is seen as the goal to be universally adopted in 10 years. So from there you can progress. And you can progress with help. The Notify project, that dimension of global governance, global tool for vigilance and surveillance, is meant to support and the link between the ANVISA and the Notify project, and will help in there. I want also to underline that I'm certainly happy to see how important patient safety is seen in this country.
Here?
I'd like to add a comment on that particular topic, if I may. I think already you have an advantage in the sense that you have a single regulator that is managing this vigilance system already across the subjects. Already this is a great achievement. And in, I would say, the majority of European countries, that isn't the case. We have still the silos that Luc referred to, and we hope to build bridges across them, of course. But I think there are two things that really help with the integration of these different systems. One of them is reporting criteria that are generic. So when we agree on our reporting criteria, they should describe not specific types of reactions and events that occur for specific types of human applications, but we should describe criteria for reporting that apply equally, regardless of the type of human product that we're talking about. And the second one is about communication, because you have the opportunity now with ANVISA to feed back to the community in an integrated way. I think this is hugely beneficial, because as soon as somebody who thinks that they have, somebody working in hematopoietic stem cell transplantation, who thinks that they have nothing to do with cornea transplantation or organ transplantation, when they see the feedback coming from the vigilance system and they see about a transmission of, I'll say, West Nile virus, because for us that's quite new in Europe, even in a field that has nothing to do with them, they will be very interested. So I think feeding back in an integrated way is a very, very valuable thing to do.
I think the point about having a single regulatory process is an important one, and you should build on that. In the United States, it is a problem for us because we have organs regulated by one entity and blood regulated by another entity, and the communication gap there is significant, and the rules are very different. So you have the ability to begin there, to build these bridges between the various communities to develop the vigilance systems. I might also point out that the Unidade project, followed by SOHO in Europe, also developed a lot of tools for assisting with definitions of adverse reactions, events, and severity scores, et cetera, imputability. These are all important, and you can learn from those, and probably those tools are available to be used.
One more. The last one, please.
Bom dia, meu nome é Leonardo, eu venho do Acre, lá do meio da região amazônica. Eu estou lá há 13 anos, eu trabalhava no Rio de Janeiro, eu sou neurocirurgião. Eu queria fazer uma colocação, porque é uma colocação da natureza humana. Nós, pelo menos aqui no Brasil, na nossa cultura, quando você diz assim, vigilância, causa um impacto emocional de alguma coisa assim, poxa, eu estou sendo vigiado. Ora, eu já tive um trabalho tremendo para conseguir com o governador me comprasse uma centrífuga para o meu hemocentro. Eu não trabalho com hemoterapia, eu sou neurocirurgião, mas eu já dirigi uma Santa Casa. Então, para comprar uma centrífuga, eu tinha problemas terríveis, que eu tinha, era necessário, eu tinha que providenciar situações de imagens lindas, maravilhosas e projetos excelentes, tá? Mas as minhas derrotas eu não contava quase todas, tá? Na minha vida prática, eu tenho o hábito de descrever os acidentes que ocorrem durante o ato cirúrgico, se ocorrerem, mas a grande maioria dos neurocirurgiões e cirurgiões gerais não descreve acidentes durante as suas cirurgias, tá? E são muito claros lá dentro do centro cirúrgico, no tete-a-tete. Porém, quando eles vêm para um congresso e falam no microfone, eles só contam as vitórias. Então parece que tudo é maravilhoso lá no trabalho dele, quando na verdade não é. Então, uma proposta, por exemplo, uma ideia, pelo menos para mim e para nossa cultura. Quando eu digo Agência Nacional de Vigilância Sanitária, opa, eu estou sendo vigiado. Agora, se eu falo Agência Nacional de Controle Sanitário, eu mudo completamente o efeito disso sobre o meu axiograma, ok? Então, eu gostaria de saber a opinião de quem quiser se manifestar e já, antes de escutar, parabenizar a todos pela apresentação que fizeram. E me desculpar, porque eu, desde o início do Congresso, eu já estou sendo considerado o chato. Aquele neurocirurgião lá do Acre, aquele cara que toda hora faz uma pergunta. Obrigado e agradeço as opiniões.
Thank you very much. Well, I will ask Geni. Geni? Oh, look.
Just a small comment.
Oh, yes, of course.
I heard you with a lot of interest because this is the reality. We must be careful about the perception we have. The word vigilance is coming from Latin, and I'm always remembering that it means watching indeed, but it also means, and that's the meaning I would like everybody to remember, caring for, caring. We're caring for what we're doing. We're caring for the medical products of human origin. We're caring for the donors. We're caring for the patients, and we like what we're doing. So that's the spirit we should keep. But I agree with you. We're using jargon. Surveillance is a technical world for methodology in detecting issues of interest, and vigilance is I'm used to say it's an attitude. But remember the caring one. So if you have a different word in Portuguese to convey this, it's the right thing to do.
You said that it's unique culture in your country, but I think it's universal. No one wants to report their errors, but if it can be positioned in a way that it's not reporting your errors, but it's sharing accidents and errors that occur that might be able to be improved upon, that could be eliminated by changing practice, because as Deidre has said, often these errors are due to procedural problems. Not necessarily, I mean, we have human errors, of course, but the procedures that are carried out sometimes are the real problem, not the individual. So across the world, as I mentioned, reporting your mistakes, nobody wants to do that. But we can't focus on the individual. We want to focus on the process and how we might improve it to improve patient safety.
Sorry, I think we will have to close this session because we can discuss too much about words and things, but indeed organizers want to close. Okay, there's another one.
Okay. Great. Sorry, I just have one other comment to make briefly. Well, first of all, I think, coming from the United States, I think it is a very encouraging thing to be able to develop a system from the start, unified, as opposed to a fragmented system like we have in the United States, which we're trying to cobble together between blood, organs, and tissues. I think that the issue here in talking to the audience, though, is that any system needs the clinicians to participate and for them to understand the value of it in order for it to succeed. So I ask you what you think the audience should take to where they work in terms of messages for biovigilance. How should they work in their facilities in order to enhance this concept so it becomes successful?
just to reiterate, I think it's quality management, and the message is that these systems can improve the quality of your practice. Even though you may never make a mistake, actually things happen that you can't control. And if you deal with this as a quality management system to improve patient safety, that's the focus I think that it needs to take, not just reporting errors for reporting sake.
Sorry, we have to close. Thank you very much to everyone.